So we're going to go ahead and get started. This is where we left off at the end of PASS. And so this is objective number 6. Describe the 4 components of synovial fluid joints, including location and function. So the 4 components, first off, are the articular capsule around the outside. Also can be called the fibrous. So she calls it that. Don't be confused or thrown off. The articular cartilage, the synovial membrane, and synovial fluid. Great. Okay, so the articular capsule, there are 4 types of joint receptors. There's probably going to be a question on this. So know these joint receptors. So just know that 1 through 3 is mechanoreceptors and proprioceptive function. So that's going to be telling you like what you're doing in space, like literally where you're at in space. So type 1 is going to be monitoring your joints at rest. So like right now while you're just sitting there. Type 2 is going to be just normal movement, like walking. And then type 3 is going to be your tendons during movement, like if you're running or jumping. Very good. And then type 4, just remember those are your nociceptors. That's going to be your pain receptors. That's what tells you that your tissue is being injured. They're non-encapsulated, non-myelinated, free nerve endings. Let's see here. Sorry, I dropped my pencil. Okay, so now we're going into the synovial membrane. So synovial membrane covers all non-articular surfaces lining the synovial cavity. So there's 3 modifications. We have synovial villi, articular fat pads, and synovial menisci. This is all just to expand our surface area to spread synovial fluid. So synovial villi, they're going to be extensions at the ends. They're just going to be filling the joint space. See these guys right here. They're like little fingers sticking out. The big thing about synovial villi is to remember is that they increase with age. So like we had said that vertebral body height decreases with age, which makes sense. Synovial villi increase, so that's kind of weird. So remember that. Articular fat pads, Haversian glands. This is just a fibrous layer of the synovial membrane, and it fills the gaps outside. So like that pink right there that I have colored in right there, that's going to be your fat pad. And then synovial menisci or intra-articular discs. So synovial menisci is split, where an intra-articular disc is like completely through. So see this right here, one we see all the time in our, or one we see is in our TMJ joint. We have our intra-articular disc and that never breaks. But anyways, they're just fibrocartilaginous projections from the synovial membrane. And they can become entrapped there all along the vertebrae, and they can, like if you wake up with a kink in your neck in the morning, that's what's entrapped. As well with the synovial membrane, the outer fibrous layer is continuous, with the articular capsule, and it contains connective tissue, blood vessels, lymphatics, and nerve endings. The inner cellular layer, this is the super important layer. It's also called the synovial lamina intima, know that name. The synovial fluid is secreted here. So this is what provides the nutrition to our cartilage. The synovial fluid that is made by the synovial membrane. So type A synoviocytes, they're phagocytic cells. They're going to be cleaning everything up, getting rid of the waste. Type B synoviocytes are the ones that actually secrete and make the synovial fluid. So they secrete hyaluronic acid, all that kind of stuff. So where is synovial, a good TQ is where is synovial fluid created? That'd be in the synovial membrane, and what cells create it? it's type B. So articular cartilage, articulating surfaces are covered in hyaline cartilage. They're avascular, they lack lymphatics and innervation. So if it gets injured, it's going to be really hard to regenerate that cartilage. Nutrition and waste elimination is provided by synovial fluid, blood vessels, sinuses of the bone marrow, because they do not have their own vasculature. They have lots of proteoglycans, lots of water, and they also have a bit of type 2 collagen and proteoglycan gel. Synovial fluid, I always had the misconception that we had a lot in our joints. Turns out, nope, low volume. And then it's just modified tissue fluid consisting of fat, salts, albumins, and hyaluronate. And the hyaluronate is just it's a lubricant. So the synovial lamina intima cells, like we said up here, remember synovial lamina intima cells? Yay. They secrete additional substances to produce the final consistency, which is we have wandering blood cells and connective tissue cells, which will help in the regeneration and healing of the articular cartilage. So functions of the synovial fluid, once again, it's a nutrition source. That's the big one. And it's a lubricant. And with the nutrition source, it can also get rid of the waste, remember? So don't forget that. Okay, we'll go ahead and go into the cervical region. So differentiate typical versus atypical cervical vertebrae. Easy questions. Don't get these wrong. For typical, there's 4. It's going to be our C3 through C6. And then for atypical, it's going to be our C1, C2, and C7. How many total? 7. 2, describe orientation of superior and inferior articular facets. So typical superior articular facets, those are going to be bum. Typical inferior articular facets, that's going to be fold. And they're on an oblique plane, so they're going to be like at a diagonal like this, right? Also, just so you have all of the like facet facing stuff on one page, I put the atypical cervical vertebrae. So C1 is bum, BMD, and then C2 is bull fold, and C7 is bum fold. Okay. So, what forms articular pillars and which muscles attach here? So, the superior and inferior margins of the cervical articular processes form the articular pillars. So, superior articular process, inferior articular process, looky there, the articular pillar right in the middle. The muscles of attachment, just have to memorize these: longissimus cervicis, capitis, semispinalis cervicis, capitis, multifidus, and rotators. Seeing these in lab is helpful. I don't know if you're there yet, but it will be. Describe which osseous structure houses the vertebral artery. So I think you guys can all answer this one, hopefully, but it is the transverse foramen. And transverse foramen are only found in the cervicals, and sometimes it's not even found on C7 because that's a transition zone. So, understand the 5 osseous parts of typical cervical transverse process. So we have the, let's see here, get my colors out. The costal element. That's gonna be right here. Costal element. We have the anterior tubercle right here, because this is, remember, this is anterior and this is posterior. We have the true transverse process right here. We have the posterior tubercle right here. We have the costotransverse bar right here. Yeah? Cool. Okay. Describe the anterior and posterior tubercles and their associated structures. So, let's see here. The anterior tubercle, so this is just going to be the tip of the costal element. Right here, or purple. Tip of the costal element. Posterior tubercle, that's going to be tip of the true transverse process, sorry. Tip of the true. So it's really important to know for this stuff how to put it into words, because you're not going to be given pictures. It's really easy to see on pictures, but you're not going to have that during the exam. So be sure you can talk yourself through where is this at associated to other structures on the vertebrae. Super important. Number 7, which nerve structure runs along the costotransverse bar? Sulcus for the ventral primary rami. It runs on the superior surface. You just got to know it. Number 8, describe the carotid tubercle. What level is it found at? C6. What osseous structure does this take place of? The anterior tubercle. This is a great place this is normally where you take your pulse, and a great place to take your pulse, because you can push that artery right up against the carotid tubercle, and then you can feel it really well. So, describe a typical cervical vertebral body and its joint surfaces. So normally, the body is rectangular. It has superior and inferior epiphyseal rims. It increases in size from C3 to C6, and aging diminishes the height of the vertebral bodies. That's what I was talking about, right? Let's see here. And then there's 5 superior joint surfaces. There's the anterior groove, the posterior groove, left and right unsnate processes in the superior spongy bone surface. So we can see that right here. Anterior, posterior, left and right, and spongy bone. On the inferior, it's exactly the same, except remember it's lips. So anterior lip, that's the anterior lip, posterior lip, right and left. Lateral grooves, and then the spongy bone right in the middle. And then, so that is a total of 10 joints on the vertebral body. There's 4 fibrous syndesmosis, so that's going to be where our ALL and PLL are attaching. And then there's 4 joints of Luschka, 1 on each side, 2 on the top, 2 on the bottom. And then there's 2 cartilaginous symphysis joints. Don't forget those. Remember, those are the intervertebral discs right in the middle. Right here, I just put this here so you could see once again remember that is where the ALL and the PLL attach. Other things that I think are important but aren't objectives that are just good to know. The vertebral foramen is triangular heart-shaped. I actually think we had a question on that, but it wasn't in the objectives, so I don't know. The unsnate process, we have elevated superior epiphyseal rims. They increase in size into adolescence. They get a little bit taller. There's no gender bias. The lips and grooves are found between the unsnate processes. The lip is on the bottom. I always remember the lips are on the bottom because when a kid pouts, he sticks out his bottom lip. And then the grooves are on the top. And then, let's see here. They participate with the intervertebral disc to make a synovial saddle joint. The pedicles, they create the intervertebral foramina, and so that's the superior and inferior vertebral notches, and they equally form the intervertebral foramina height, I think. Did I have right here. The top is equally as big as the bottom notch. That's basically what's that saying. And then the lamina, the ligamentum flavum attaches there. If you have ossification of that, it's para-articular process. Understand and describe the cervical lordotic curvature. So the posterior height of the vertebral body is greater than the anterior height, so you can kind of see that here. But it's a lordotic curve, which we don't normally see if the posterior height is greater than the anterior height. If you just think about it, usually they would inch and curve towards the anterior. But we have the intervertebral discs that compensate for this. So the intervertebral discs are almost kind of like this in between. So that way we can have that lordotic curve. And like I said, without it, it would be a kyphotic curve. Number 11, describe osseous structures located on the anterior and posterior arch of C1. So C1, there's no body or spinous process. It contains articular surfaces for the dens and the occipital condyle. Dens, it's going to go right there, and then the occipital condyles are going to articulate right there. The anterior arch, we have the anterior tubercle and the fovea dentis. And then we have attachment sites for the ALL, the anterior atlanto-occipital, the anterior atlanto-axial, and the longus colli muscle. Those first three make sense, right? And then if you think about it, and then so you just have to remember longus colli muscle. This was a question on our exam, super easy. She'll ask, or she did for us, what attaches at the anterior arch, or which one of these doesn't attach at the anterior arch? And then she has three of them, and then put something random. Between the dens and the osteoligamentous ring anteriorly, we have the transverse atlantal ligament posteriorly, and that's going to make the medial and atlantoaxial joint. So the transverse atlantal ligament will go like right here around the dens and create the osteoligamentous ring, and which is a synovial pivot joint. The posterior arch, we have the posterior tubercle of the posterior arch. You have to put posterior arch because guess what? We have a posterior tubercle on the transverse process. So with that being said, we also have the arcuate rim, right? And then we have the groove or the sulcus for the vertebral body, for the vertebral, that should be artery. Artery. And a possible ponticulus posticus and arcuate foramen formation, which we talk about here in a little bit. The lateral masses is the joint between the occipital condyles of the occiput and the lateral mass of C1. It's a synovial ellipsoidal. Know that it is synovial ellipsoidal. That Miss Beveridge said is a frequently missed question. And then it's condyloid, oval in shape. The way you can always tell is the top ones are, or the way you can tell the top from the bottom is the top one is kind of like a peanut. And then the bottom ones are more circular. Transverse process. So what is different on the C1 transverse process compared to the typical vertebral transverse process? So we have number 1, which is going to be our costal element. We have number 2, which is going to be our posterior tubercle of the transverse process. Because remember, where else do we have one? On the posterior arch. So you have to be specific. And then number 3 is our true transverse process. Cool. Number 12, understand homologous structures of C1. So our anterior arch, I put these two pictures next to each other so you could kind of compare them. The anterior arch is comparable to the pedicles. Kind of makes sense. If there was no body here, the pedicles would connect. That's how I thought about it. The lateral mass, the is homologous to the articular pillars. Right there, that makes sense. They're both on the side. The posterior arch, homologous to the lamina. That makes sense. Posterior tubercle of the posterior arch, homologous to the spinous tubercle. Makes sense, right? Okay, describe ligaments and joint surfaces associated with C1. So we have the fovea dentis, which is going to be the median atlantoaxial. Remember, the median atlantoaxial joint is different than the lateral atlantoaxial joint. You have to keep those straight. This fovea dentis is the synovial pivot, where the lateral atlantoaxial joint just articulates with the superior articular facets of C2. Okay, the superior facets are the atlanto-occipital joint. That makes sense. Once again, synovial ellipsoidal. This is golden. I just copied and pasted this from my notes because I don't think I could do it any better than Miss Beveridge already has. I also put it if you want to do your own writing. But the ALL runs right up the middle in the red. The tectorial membrane, extension of the PLL, right in the middle once again. The anterior and posterior atlantoaxial ligament, the blue and the purple. The anterior and posterior atlanto-occipital, the blue and the orange. And then you can follow all these. So you have to know all of these. It's easier with a picture, but you also have to know in your head that C1 has all of these joint classifications, right? There's 6 fibrous, 1 synovial ellipsoidal, the atlanto-occipital, 1 synovial pivot, the median atlantoaxial, 1 synovial plane, the lateral atlantoaxial. Here's a complete list, just for you guys to have. The tubercle is here. I'm trying to see what's different on here, or what I added. The tubercle for the transverse atlantal ligament, right? So that is going to be right here where it attaches. Everything else I think looks about the same. All right, so we are going to describe the ponticulus posticus, the vertebral artery, arcuate foramen, and the retrotransverse foramen. So the accessory bone formation creates the ponticulus posticus, and this is going to be ossification of the posterior atlanto-occipital ligament. I don't believe that was on the notes, but I think it was on like some practice questions she had given us, so I just wanted to throw it in there. This is going to occur between the lateral mass and the arcuate rim, and it occurs over or superior to the groove of the vertebral artery. So it can be bony extensions and incomplete like these guys, or a complete formation is going to form our arcuate foramen. So like this. The vertebral artery can pass through here, and it can be a form of compression. It's also more prevalent in females, so there's some gender dimorphism there. But it's going to go, so normally it goes through the transverse foramen, right? Then it's going to come back through, go through the arcuate foramen, and then up the spinal cord. So that's obviously, twisting and turning like that could be a cause of compression. Then we also have a retrotransverse foramen, which is between the lateral mass and the transverse process, different than the arcuate foramen, which goes to the arcuate rim. So remember, those are different. It may be complete or incomplete, and it can contain the vertebral artery, suboccipital nerve branch, and the communicating venous sinus vein. So now looking at these pictures, this first one, do we think that that is the retrotransverse foramen or the ponticulus posticus? Well, let's look at where it's going to attach. So this is incomplete, but it's coming off the transverse process and it's coming off the lateral mass. So that would be our retrotransverse foramen. This one is coming off the arcuate rim and our lateral mass. So that is going to be our ponticulus posticus, and it's fully formed. It's fully formed, as we can see. So that's actually going to be the arcuate foramen. Okay, next, describe ligaments and joint surfaces associated with C2 and C7. So the C2 joint surface, it has quite a few. So on the dens, there's the facet for the fovea dentis, which is going to be right here. Then we have the groove for the transverse atlantal ligament, which is going to be like this guy right here and here. The apical dental ligament, those are going, that's going to attach right at the top. And then the left and right alar ligaments are going to attach right there, right? And then the facet for the fovea dentis, that's a synovial pivot joint, right? That's why we can rotate our head. Groove for the transverse atlantal ligament, synovial pivot as well. And then the apical dental and the alar ligaments are fibrous syndesmosis because they are ligament attachments. The inferior epiphyseal rim is just the same as normal. So on the anterior lip, we're going to have the ALL, posterior lip, the tectorial membrane, because remember, this is where we're transitioning from the PLL. The right and left lateral grooves, and then the cancellous bone, or the spongy bone right in the middle, your intervertebral disc. Don't forget about that one. That one's important. It's a cartilaginous symphysis joint. She really liked that. She'll probably quiz on that, so remember that. And then don't forget there's superior articular facets and inferior articular facets still. So those are still joint surfaces that you need to take into consideration if she's asking you how many joint surfaces are on, let's say, the C2 joint surface. So the ligaments, we have the apical dental, which is this guy right here, the alar ligament, of course, these guys, and the transverse atlantal, which would go right around the neck. This is just an exhaustive list of the ligaments of C2 and where they are found. It's like the ALL, the vertebral body, the inferior part of it. So yeah, that's just for you to have. Okay, joint surfaces of C7. So the superior vertebral body joint surfaces, there's the unsnate process, which is the joints of Luschka, synovial saddle. There's the intervertebral disc, cartilaginous symphysis, the ALL, the anterior groove, PLL, and the posterior groove, which are fibrous syndesmosis. So there's 5 total on the top. Let's see. 2 unsnate process, ALL and PLL, and then the IVD, 5. The inferior vertebral body joint surfaces are the anterior margin of the inferior epiphyseal rim, which is where the ALL attaches, the posterior margin, which is where the PLL attaches, and the cancellous bone, which is the intervertebral disc. So there's 3 total on the bottom. And then we also have the superior and inferior articular facets. Once again, do not forget these. They still exist. And these are our zygapophyseal joints, our plain synovial joints. So this question, tons of people miss this just because they weren't really thinking. So she could ask, how many joint surfaces are on C7? If she asks that, there's 10 total because of our superior and inferior articular facets. She may just ask how many joint surfaces are on the body. That's 8. So be sure you're really reading those questions and thinking about where she is talking about. The ligaments of C7, we have the ALL on the inferior vertebral body, PLL, the interspinous ligaments found throughout the spine, then the ligamentum flavum, which attaches to the lamina. Okay, so now we'll be doing number 16, describe the vertebral body and vertebral arch, C2 and C7. So for C2 body, do we have a vertebral body? The answer is yes, unlike C1, where we don't have one. And then do we have anterior and posterior grooves? That is a no, because we have the dens. In unsnate processes, we do not on superior surface. Once again, because we have that dens. Is the inferior aspect the same as typical cervicals? Yes. That's going to have the anterior and posterior lip, the right and left grooves, and then the spongy bone in the middle. And then this is the thickest and strongest cervical vertebrae. Midline elevations at C2 body represent the longest colli muscle attachment site. This was a question that she had done in class, but she did not ask it in our exam. The attachment site for the ALL, it attaches to the vertebral body. This is super important, and I believe she asked a question on this. It attaches to the vertebral body, not to anywhere else, just something you have to know. The inferior surface attachments are the ALL, the PLL, and the tectorial membrane. So the C2 vertebral arch, the pedicles are large and broad. Right here, they're huge. The superior and inferior facets. So in children, they're going to be in a horizontal orientation. So they're going to be like laying flat, pretty flat. And then in adults, they start to like go into that oblique orientation, kind of, so like horizontal, oblique at an angle. The transverse process, there's no costotransverse bar or anterior tubercle. It's the same as C1. And then I was going to say right here, we have our costal element, posterior tubercle, true transverse process, right? The spinous process, C2 through C6 can be bifid or non-bifid, and C2 is the largest bifid spinous process. So C7, with the body and the arch, I put all of that on one slide for C7. So the vertebral body, it's rectangular in the cervicals and then triangle in the thoracics. So this is at like that transition zone. The superior epiphyseal rim, we have uncinate process, anterior and posterior grooves. On the inferior epiphyseal rim, we don't have any defined structures, so it's just kind of sitting there, just chilling. Because once again, this is a transition zone. So the top represents the cervicals and the bottom is going to represent the thoracics more. The transverse process, so we don't always have a transverse foramen right here. So the artery doesn't always enter there. It enters at C6 a lot of the time. And then it's the same as typical cervicals because we're in that transition zone. And then for the vertebral arch, we have the superior articular facets, which are going to be bum. And then we have the inferior articular facets that are going to be fomed. Once again, this is because the transition zone, the superior is going to be like the cervicals, and the inferior is going to resemble the thoracics. So you'll learn that the thoracics are fomed, the inferior articular facets. So the spinous process, it's long, horizontal, non-bifid, and it has a spinous tubercle at the end, of course. So 17, describe the vertebral artery, embryology, and subdivisions. So it appears at day 33 in utero. It's fully developed by day 54. I don't think those are super important, but I just threw them there because she didn't have much on embryology. But this right here is so important. So as you can see in this picture, the aorta, which is like right here, the aorta gives off the subclavian artery, which then is going to run to your clavicles, right around your clavicles, right? So then from there, the vertebral artery branches off and keeps going superiorly. So you need to know it goes aorta to subclavian artery to vertebral artery. she asked a question on that. That was on our exam. And I don't think I had studied it. So be sure you don't, be sure you're not me. Let's see here. Also, the left side diameter is greater than the right side because the aorta runs on the left side, which is where we get the blood from. And then it tends to be larger in males than females. But yeah, that's it. If you have any questions or if I said anything wrong, feel free to email me because I'm human. I'm bound to get something wrong. And if you have any questions, I'm happy to answer them. And whether it be about this class, about a different class, about lab, I'm here to help you guys. So just feel free to reach out.